Hello, we are from Carroll University's Master of Science in Clinical Exercise Physiology program. We have collected data that helped us determine whether the Shackelford treadmill protocol, which was originally designed for cancer survivors, provided an accurate measure of VO2 peak among obese and apparently healthy populations. Thank you for taking the time to listen to our presentation and findings. One of the most common chronic diseases is obesity, as 41.9% of U.S. adults classified as obese. Worldwide, there are 1 billion people who are classified as obese, nearly doubling since 1980. Obesity is related to other conditions such as heart disease, stroke, type 2 diabetes, and certain types of cancer, which are among the leading causes of preventable death. Obesity leads to physiological impairments that reduce cardiovascular function and the ability for individuals to perform activities of daily living. These limitations range from muscular degradation, joint remodeling, excess cellular stress, and increased ventilation and heart rate. The increased adiposity within this population leads to joint structure damage and reduced muscular strength through chronic inflammation and abnormal adipokine production. This combination leads to reduced joint reabsorption and formation, accelerating the risk of osteoporosis. Excess adiposity also surrounds the lungs and diaphragm, limiting movement and increasing ventilation rates to maintain adequate oxygen supply, resulting in increased heart rates. These factors all come together to cause stress on the physiological systems of the body, impairing cardiovascular capacity. As exercise physiologists, our understanding of physiological mechanisms behind diseases and their related impairments helps us create individualized exercise interventions to limit or mitigate the risks and impairments associated with chronic diseases. In order to create an effective and individualized exercise prescription, a valid graded exercise test is needed to obtain peak volume of oxygen consumption, or VO2 peak. VO2 peak is the gold standard measure of aerobic capacity, allowing for the evaluation of how well the body utilizes oxygen during exercise. This measure also has an inverse relationship with mortality, as a high VO2 peak is representative of a low mortality rate, and a low VO2 peak is representative of a high mortality rate. VO2 peak and its classifications based on sex and age become the foundation for the exercise prescription, giving clinicians rationale for a starting point for exercise interventions. Without a valid GXT that accounts for population-specific limitations such as cachexia, peripheral neuropathy, or musculoskeletal impairments, VO2 peak values may overestimate or underestimate the cardiovascular capacity for individuals, leading to an ineffective program. Currently, the most used treadmill protocol is the Obese protocol. This protocol entails 3-minute stages, increasing in grade, speed, or both, with an initial MET requirement of 5 METs. The starting MET requirement alone may be too aggressive for some to sustain for an entire stage due to their deconditioned status. Every stage progression after the initial stage increases by 3 METs after each stage. This progression rate may be too intense for the chronic disease population, with all their related impairments and limitations, especially those suffering from cancer. In fact, our most recent manuscript demonstrated this exactly, which showed that the Obese protocol is inaccurate for cancer survivors due to cancer and its accompanying toxicities. Similar results may be experienced with those with obesity, given the impairments that are common among the obese population. Due to this, ACSM recommends using treadmill protocols that begin at low initial workloads of 2 to 3 METs and progressing at a slow incremental rate of 0.5 to 1 METs per stage to match their functional abilities and account for disease-related limitations. There is emerging evidence suggesting the optimal duration for a graded exercise test is no longer 8 to 12 minutes. Instead, test durations lasting from 5 to 26 minutes elicit accurate VO2 peak measures across populations. With the increased time frame for VO2 peak testing, protocols that can accommodate disease-related impairments may be used for the apparently healthy populations, dependent on a protocol's ability to progress to a high enough intensity to elicit an accurate VO2 peak among both respective groups. With the Shackelford treadmill protocol's testing duration spanning up to or greater than 20 minutes, there are questions surrounding its ability to elicit cardiovascular fatigue among the apparently healthy population. due to the low intensity progressions. However, the intensity elicited throughout the Shackelford treadmill protocol closely matches the intensity level reached by the Bruce treadmill protocol, just over a longer time span. With the newly cited timeframe, a longer duration, and progressive protocol may allow for an accurate measure of VO2 peaks explored within this study.
Treadmill tests are essential assessments that may be used for stress testing to diagnose coronary artery disease and can identify signs or symptoms suggestive of cardiovascular, metabolic, or renal diseases. Choosing an appropriate treadmill protocol is crucial to eliciting true cardiorespiratory fatigue for diagnosis, prognosis, and an evaluation of physiologic response to exercise, influencing the exercise prescription. Regarding exercise prescription, establishing VO2 peak may be the most important. The Shackelford treadmill protocol was originally designed as a graded exercise test protocol to accurately obtain VO2 peak in the cancer population. Individuals with cancer and cancer survivors suffer from many disease and treatment-related toxicities that can hinder their ability to reach true cardiorespiratory fatigue with other treadmill protocols, as our most recent manuscript outlines in more depth. Common cancer-related toxicities consist of cachexia, decreased aerobic capacity, osteoporosis, osteopenia, and peripheral neuropathy. The Shackelford treadmill protocol helped create a tool for a clinical exercise physiologist to measure VO2 peak and create an accurate exercise prescription. Other chronic diseases like obesity experience similar limitations. There are many different treadmill protocols utilized today. However, most are only validated in apparently healthy populations or are valid in one disease population. For example, the Naughton treadmill protocol for cardiac clients or the Shackelford treadmill protocol valid only in cancer survivors to this point. The Shackelford treadmill protocol's low intensities and slow progression may accommodate disease-related toxicities within other populations like obesity. Therefore, this study, we wanted to see if we could validate the Shackelford protocol in the obese population as well as apparently healthy individuals.
The purpose of this study was to examine the validity of Shackelford protocol and American College of Sports Medicine walking and running equations in the obese population and apparently healthy. Although previously cancer-specific, we observed whether the Shackelford protocol could accurately predict the VO2 of other populations, including those with a chronic disease and apparently healthy individuals. This was due to the fact that many treadmill protocols are unable to accurately measure VO2 peak in populations spanning from apparently healthy to those who have a chronic disease. For example, the Bruce protocol was validated on apparently healthy college-aged individuals, which excludes a large portion of the population.
The subject demographics that were represented in our research included 48 total participants. Of those 48 participants, 16 presented as cancer survivors with a current cancer diagnosis, 60 presented with a BMI greater than or equal to 30, classified as obese, and 16 were considered apparently healthy without the presence of a chronic disease. This experiment used a repeated measures design analyzing cardiorespiratory fitness using a multitude of variables, such as VO2, respiratory exchange ratio or RER, respiratory frequency or RF, rate of perceived exertion, heart rate, blood pressure, and oxygen saturation. A Cosmed brand metabolic cart utilizing direct gas analysis was used to obtain actual VO2, which is the gold standard in measuring and recording VO2 during an exercise test. All participants performed the Shackelford treadmill protocol until volitional fatigue. RER, heart rate, RF, and VO2 were continuously monitored and recorded throughout the test, using the highest value of RF and RER within the final 30 seconds before maximal VO2 was achieved. Other vitals such as blood pressure, RPE, and SpO2 were also recorded per each protocol and again during recovery. The ASM walking and running equations were used to obtain estimated VO2 peak with speed in meters per minute and grade in decimal form.
On this slide, we have the Shackelford treadmill protocol, previously referred to as the cancer treadmill protocol, first validated in cancer survivors. This protocol increases in intensity by speed, grade, or both every minute. The first stage starts at 1.8 METs and increases by less than 1 MET each stage, which is essential for those with a lower cardiovascular capacity, as it allows further progression throughout the protocol. Other protocols, such as the Bruce, start at a higher initial MET level and further increase at approximately 3 METs per stage. It can be difficult for many individuals to maintain large increases in intensity, especially over 3-minute stages. Protocols with 1-minute stages, such as the Shackelford treadmill protocol, may provide a more accurate representation of VO2 as estimation equations used to determine VO2 peak use the last completed stage rather than the stage in which the individual terminated. For example, if an individual terminates within the first 10 seconds or the last 10 seconds of a 3-minute stage, their VO2 peak estimation is the same. When using a treadmill protocol with 1-minute stages, the estimation of VO2 peak is more representative of an individual's cardiovascular capacity. The Shackelford treadmill protocol can be extended if an individual exceeds the last stage of the protocol, increasing the intensity by 0.1 miles per hour in a 1% incline every minute until the individual reaches their true cardiovascular fatigue.
A paired samples t-test was used to determine the level of significance in the comparison of actual VO2 peak to estimated VO2 peak between all subjects. A non-parametric independent samples Kruskal-Wallis test was used to determine differences of actual VO2 peak and estimated VO2 peak between the cancer, obese, and apparently healthy populations. Finally, a non-parametric related samples Wilcoxon signed rank test was used to determine the level of significance when assessing whether actual VO2 peak and estimated VO2 peak differed within each independent group. The researchers used a confidence level of 95%, or 1 minus alpha equals 0.95, and an alpha level of 5%, or alpha equals 0.05, when running each statistical analysis. Thus, if a p-value was reported over 0.05, there is no significant difference, whereas if a p-value was reported under 0.05, there is a significant difference. Figure 1 represents the comparison of actual VO2 peak and estimated VO2 peak between all populations. The y-axis of Figure 1 represents VO2 peak in milliliters per kilogram per minute, whereas the x-axis represents each population. Each population has 2 corresponding columns. The blue column, or the leftmost columns, represent actual VO2 peak, while the orange columns, or the rightmost columns, represent estimated VO2 peak. Estimated VO2 peak was calculated using the ACSM walking or running equations, which used relevant data obtained when measuring actual VO2 peak. The obese population showed a mean actual VO2 peak of 26.9 milliliters per kilogram per minute and a mean estimated VO2 peak of 24.7 milliliters per kilogram per minute. The cancer population showed a mean actual VO2 peak of 28.0 milliliters per kilogram per minute and a mean estimated VO2 peak of 27.8 milliliters per kilogram per minute. The apparently healthy population showed a mean actual VO2 peak of 38.3 milliliters per kilogram per minute and a mean estimated VO2 peak of 38.7 milliliters per kilogram per minute. These results showed no significant difference between actual VO2 peak and estimated VO2 peak between all populations. Figure 2 is directly comparing actual VO2 peak values between the obese, cancer, and apparently healthy populations. The y-axis of the chart represents actual VO2 peak in milliliters per kilogram per minute, whereas the x-axis represents each population. The orange column, or the leftmost column, represents the obese population. The gray column, or the middle column, represents the cancer population. And the blue column, or the rightmost column, represents the apparently healthy population. Mean actual VO2 peak values for each population were as follows: 26.9 milliliters per kilogram per minute for the cancer population, 28.0 milliliters per kilogram per minute for the obese population, and 38.3 milliliters per kilogram per minute for the apparently healthy population. Above the apparently healthy column, you will notice alpha and beta symbols. The alpha symbol represents significant differences in actual VO2 peak between the apparently healthy and obese populations. The beta symbol represents significant differences in actual VO2 peak between the apparently healthy and cancer populations. The main findings of this study will be discussed in the next slide.
Let's go ahead and break down the results that were just explained. Within each individual population, the estimation of VO2 peak determined from the ACSM running and walking equations present the same value when compared to the actual VO2 peak obtained from the metabolic cart. It was also found that there was a significant difference between actual and estimated VO2 peak between the obese and the cancer survivor population to the apparently healthy population, which is supported by the p-values for 0.017 and 0.019 respectively.
The gold standard in obtaining VO2 peak is through a MET cart. However, the usage of the metabolic cart in the clinical setting is not always feasible due to financial or personnel costs, or
due to the potential negative impact the equipment has on the individual's performance. The gas analysis mask itself may cause balance disturbances in those with vision, gait, and general balance limitations. Due to these concerns, the usage of accurate estimation equations is crucial. The ACSM walking and running equations were originally only a step in finding VO2 in submaximal Bruce treadmill testing, utilizing another equation for its final estimation value, therefore indirectly using them. However, the Shackelford treadmill protocol is the only protocol validated to directly use the walking and running equations to accurately find VO2 peak. Since there was no significant difference between actual and estimated VO2 peak in all participants and within each group, this supports the validity and accuracy of the Shackelford treadmill protocol using ACSM walking and running equations to estimate VO2 peak for apparently healthy cancer survivors and the obese population.
While our results are extremely promising, limitations exist. The largest limitation we faced was our sample size. With only 16 participants for each group, our results are not as profound as they could be with a larger sample size. Another limitation we faced was the lack of controlling for outside factors. For example, we did not control for sleep patterns or dietary intake. A lack of sleep can have a negative effect on an individual's performance and could cause inconsistencies from week to week. A lack of sleep or a poor night's rest can reduce an individual's VO2 peak and create heart rate max inaccuracies. If a participant experienced a night or a few nights of poor sleep, they will be more fatigued during the test. In turn, this may result in their rate of perceived exertion to be higher at the submaximal intensity, thus leading to an early termination and an invalid VO2 peak. Similarly, dietary intake can influence how a participant feels and performs during a test. Caffeine, for example, can improve performance and potentially increase VO2 peak and heart rate. Another example would be eating carbohydrates. Eating carbohydrates prior to exercise can improve performance by providing an energy source to maintain the increasing workload of a graded exercise test, which could potentially increase VO2 peak. Moving forward with our research, we will first need a larger sample size for both obese and apparently healthy populations. While our results are promising, having a larger sample size could help solidify the reliability of the Shackelford treadmill protocol in these populations. Along with sample size, equal representation of males, females, and age are needed. Having a diverse set of participants can also help increase the reliability of the study because it would be a better representation of the population as a whole. Lastly, in the future, we would like to evaluate other chronic diseases like type 1 diabetes and type 2 diabetes, cardiovascular diseases, and pulmonary diseases. With many chronic diseases existing and 6 out of 10 adults having at least one chronic disease, it would be advantageous to evaluate the Shackelford treadmill protocol's ability to accurately evaluate VO2 peak in other populations.
It's known that increased morbidity and mortality is correlated with decreased VO2 peak, representing an overall compromised cardiovascular system. Therefore, it is crucial to choose an appropriate treadmill protocol for an individual to establish an accurate representation of their aerobic capacity. The validation of the Shackelford treadmill protocol is essential to allow for an accurate representation of clinical populations such as obese, cancer, and other chronically diseased population. The use of a metabolic cart is not always available. Therefore, the ability to use the ACSM running and walking equations with confidence of a correct estimation of VO2 peak is necessary.
Using the Shackelford treadmill protocol, cancer survivors reached fatigue due to cardiovascular reasons rather than non-cardiovascular reasons such as cachexia, osteoporosis, peripheral neuropathy, and anemia. Using this protocol allows for the evaluation of aerobic capacity rather than anaerobic capacity, which delays muscular fatigue and upregulates the sympathetic nervous system among the obese and apparently healthy populations, potentially increasing VO2 peak. Initial vigorous stages, such as the Bruce protocol, deplete phosphagen and glycolytic energy pathways, creating undue fatigue and leading to an early termination. In addition, tolerance to aggressive stage changes, such as the Bruce protocol, is inhibited in the obese population due to the disproportionate stress on joints from excess adiposity and aberrant adipokine expression, causing structural damage and remodeling of joint tissue to impair gait and tolerance. The results within the apparently healthy population were non-significant, meaning there were no differences between the actual and estimated VO2 peak. demonstrating the validity of the Shackelford treadmill protocol within this population. This result was expected as there is a similarity between METs throughout the duration of both the Bruce and Shackelford treadmill protocol. The Shackelford treadmill protocol allows clients to continue beyond 20 minutes to elicit maximal exertion and has been shown to have a positive correlation between VO2 peak stage intensities, making it a valid option for the apparently healthy population. All in all, the Shackelford treadmill protocol elicited accurate VO2 peak measurements in all our populations. While there are treadmill protocols for the apparently healthy and others for chronic diseases, the Shackelford treadmill protocol may offer a single treadmill protocol to be used across a diverse set of populations.